Let's talk about the current strategies for migraine treatment on the table that docs know about right now. Let's talk about active, acute treatment right off the bat. What is out there, and what is the strategy for dealing with acute headaches?
Well, I think most doctors know about the simple analgesics, and patients, of course, will get their aspirin or their acetaminophen or their naproxen or ibuprofen. They'll get it from the local pharmacy or wherever they get it from. So when patients come to see a doctor, the first thing for acute therapy is to make sure the dose has been adequate. Very typically, people will take a half-baked dose, 200 milligrams of ibuprofen, and may as well not take it if you're 70 or 75 kilograms. So doctors know that, ought to know, they ought to adequately dose acute therapies. And then there are specific migraine therapies that have been around for about 20 years. The so-called triptans, the serotonin 5-HT1B1D receptor agonists. Sumatriptan is the archetypical one. There's half a dozen available. And they really did quite revolutionise to some extent the acute treatment of migraine.
Okay, that's acute. Now what about preventing migraine? Where do we go with that?
Mm-hmm. And there's some common medications out there as well that have been, I think, demonstrated efficacy. So the beta blockers and the antidepressants, for example, that I think some patients really do benefit from.
Let me bring up.
Interestingly enough, from a mechanistic perspective, and I'll say it just because I think it's important. Not all beta blockers work, and we don't understand that. Not all antidepressants work. It's some beta blockers, like propranolol, there's evidence for. Some antidepressants, like amitriptyline, there's evidence for, but the studies with fluoxetine, for example, were negative. Some blood pressure drugs, like candesartan, there's evidence for, but the telmisartan study was negative. So it's interesting that we think we use those terms, blood pressure drugs and so forth, but there are some parts of those mechanisms that are clearly important and some parts that aren't.
Which is so interesting, because in other disease categories you can go across the board with them.
Yes,
except, you know what that just reminded me of? NSAIDs for heart disease. In other words, if you're going to give aspirin for prophylaxis for atherosclerotic disease, it works. The other NSAIDs not, and some NSAIDs increase your risk for heart disease. Or as my grandmother would say, go figure. You know, there's got to be some evidence here. So let's go over the triptans first of all. What's the optimal timing, a limit, the duration of therapy, contraindications? Who's going to run through this for me? Somebody.
Well,
go ahead. Well, the issue with triptans is, on the patient perspective, is patients are only given a limited number of triptans per month. And if you have chronic migraine, it's difficult to know which migraine is triptan worthy.
But is there...
So you have to ration.
Yes.
If you're going to use it, is there a best time to give it?
Yes, the earlier the better.
Okay, so if you have the aura, give it. If you're getting pain and you think this is a migraine,
yes,
give it.
But if you wait to see, is this really a migraine?
Then it's too late. But then somebody's going to deny you if you've used up your N, where N is an integer, which is probably smaller than you'd like. You're going to use up all your doses. You're not going to have it for your next migraine.
Right.
So you can understand why people would delay.
Yes, I do, absolutely. And that's an issue, but it's also a problem that if you use too many triptans, you may be susceptible to medication overuse or rebound headache.
I want to get to that. But what about cardiovascular disease? Is there an impact? And is there a problem with using the triptans in patients with ischemic heart disease?
Yes.
How? What?
Well, personally, I've tried triptans, and it really affected my blood pressure in a very negative way.
Okay.
It's contraindicated for people who have ischemic heart disease.
Okay.
And you can add to that, Dr. Goadsby.
I can. I just want to do a small fact check. The advice about using triptans early is when the pain is established. Actually using them when there's just aura without pain. There's three actually randomized control trials, placebo controls to show that actually reduces the likelihood of an outcome. So, go
really?
figure. But treating during aura is not a good idea. Not because I don't think it's a good idea. There's three trials. The important advice is to treat early in the pain phase.
So the pain, not the aura.
Yeah, just a small.
So it's like gravity. It's not just a good idea, it's the law.
Yeah.
Right.
Okay.
Right.
Let's go way back into medical history now. Ergots, dihydroergotamine. That was old when my professors were young. And yet it's still out there in the formulary. Does it work? But there's a quizzical tone to your voice here. Why?
Because there are other options that are maybe safer and more efficacious than the ergots.
Right, and I think that's the population-based versus the individual. So you look at the studies and you'll find that the triptans are better, but I think the individual in front of you may have benefit.
But I mean, ergots are really well established. They're older therapies. They've been wrung out, not for everybody. I bet they're cheap. They're cheap. So you cover them. Yeah. So let's talk about medication overuse.
Well, since the dihydrogodamine's been around since 1945. The problem, there's two problems with it. One, it induces nausea. Yep. So very often you have to take some anti-nauseant with it and accept that there might be side effects of the other thing you're taking. So it's a really unfortunate thing in medicine when you have to give adjunctive drugs for the side effect of the drug that you're about to give. It's certainly not ideal. And the second thing is the absorption rates aren't great. So they really work best when you inject them. And not many people want to break the thing open, draw it up and inject themselves when they're having a dreadful migraine.
Not recommended. And
not recommended. No,
from a purely pragmatic point of view, if you're getting nauseated and you're having vomiting from the ergots, you're going to vomit some of the ergot. It's not going to really be all that effective. So